So,
Carmesia, tell us a little bit about your work, and then tell us what kind of obstacles you run into in trying to meld the housing and the healthcare communities in the Triad.
Okay. I'm the Special Projects Manager and also Practice Administrator at a federally qualified health center. It's called Triad Adult and Pediatric Medicine. And one of my projects has been opening a medical office on the public housing campus. And so that was completed in May. And so because housing and health doesn't really talk that much, we ran into obstacles with zoning and surveying. If I were to ask you what you thought took the longest in the project, which ended up being about 2 years, it was actually the surveying and the zoning. Getting it zoned from a residential unit, because we did convert a 4-bedroom unit into a medical office. Getting that surveyed and zoned properly took a lot of time, and I actually had to change surveyors because the first surveyor didn't understand why the city was asking for certain things. So our obstacle was, this is a unique opportunity that we had converting this unit, and because it was so unique, you know, how do we deal with the local legislation about zoning to make this work? So once we began the communication with the city and we got everything under control, you know, renovations only took 3 to 4 months. So our obstacle was the zoning and the additional funding that required.
Okay. Who came up with this idea, and was there any resistance from, let's say, the housing authority, or what, well, in terms of how this came about?
The good thing is the housing authority actually did think about this, and we're in Reidsville.
Okay.
And what happened, Reidsville is in a health provider shortage area. They don't have a lot of primary care providers relative to the number of people in the area. So on the other side, on the health side, there was a group that came out called the Rockingham County Healthcare Alliance. So they were looking for a medical provider just to support the number of residents. And she met with the housing director, and he said, well, wouldn't it be nice if we could just put a medical office right here on the campus? A lot of people here don't have transportation. Rockingham County also doesn't have a busing system. They're getting better now, but they had no public transportation at the time. So she met with him, and she was like, well, maybe we can make that work. So actually the housing authority director idea was turned into the reality.
Dexter, tell us a little bit about your work and what you see as some of the major obstacles.
Yeah, so one, I'm not an expert on housing or medical or healthcare. So a lot of my job has been working in underserved communities to provide programs for youth. And so giving them access to education programs, academic programs, as well as summer enrichment programs. And so doing that for about 13 years, where now my job is merged into being a connector and a convener, and recognizing the issues and disparities that exist in those communities that I've been serving for years. And so one of the things that I recognize, and I don't know how many of you agree with this, how long have we had an equity issue in this country?
Forever.
Exactly. And how many of you have had seats at the table where folks were making decisions about things without having the community that it's impacting being, look, it's trying to shut me down right now. Stop talking about that, That was interesting.
Let there be light. Let there be light.
They're going to shut you down. You have to know how quick.
Exactly. And so when we think about obstacles or roadblocks, I think a lot of it is we have a communication problem. We have an engagement issue. We have an empathy problem. Because if you are making decisions about a community that you don't live in, that's a problem. because you don't know what's really impacting them. And then if you go find one person in that community that you think is speaking for the whole community, then you really have an issue and a problem. I think when we are doing this work, we have to be real about the equity issue that's always existed in this country. And I think a lot of times that's the conversation that makes people uncomfortable and folks don't want to talk about. So that's one of the main blockers and main issues that I see. And I'm just talking about from just the ground level. When I'm working with our families and talking about things that are going on, poverty has been generational for a long time, you know, but just because you're poor doesn't mean you should not have access. And so when you look at the biggest issues out there, it's an access issue. It's an access to quality housing. We talk about affordable. A lot of housing is affordable, but is it quality? You know, and so are we asking the right questions when we're talking about how we're working in community and trying to develop better communities for our families? And people don't understand that if you develop better communities in lower income areas, that impacts everybody around you, and then some. It's a ripple effect that takes place.
So what exactly does the Y do in this context?
Yeah, so for us, what we've been doing is connecting our community to resources that exist out there to be able to uplift, number one, the issues that are happening, but two, how can we serve the whole family in these issues and not focus on just the fish? How do we focus on the lake? Because a lot of times the lake is what's toxic. So how do we bring programs into the community? Well, we do that by bringing people to the table, and we have conversations, and we move from conversation to action. So for us, we've collaborated and partnered with folks like Raleigh Parks and Rec to utilize their centers to increase physical activity in the community. We work with the Wake County Public Schools to do the same thing when you're talking about the underserved community. So we brought Raleigh Housing Authority to the table to have conversations about how can we make the housing in these communities quality. You know, what does that mean? What does that mean to have quality housing in these communities, and how can the Y support and help you with that? So,
okay, great. So moving from obstacles to potential solutions, what have people seen in terms of model programs, innovative programs? What's the frontier here? Where's the possibility for making better connections and having healthier people? Just whoever wants to jump in on that one.
I would love to go around to every housing authority and put a medical office.
Okay, all right.
Well, first of all, he was saying the ripple effect, and that's true in our community where we are. We began building or renovating the housing space, and we said, you know, what else can we do from a community perspective to make this community better, so to speak? Not trying to be the hero, but trying to be a partner. And so we applied for a grant for a community garden. We didn't get the grant, however, the people in the community were still invested in the idea, and they actually have a community catalyst there, so they got grant funding elsewhere and they were able to do the community garden. So that was one ripple effect of just our presence there. People are starting to look more at the community. Then Kaboom, it's a playground build organization where kids design the space and then you come out and you build it in the day. We just finished the Kaboom playground on November 1st. So they had a small playground, 2 separate small playgrounds, but it was old, it was falling apart. So now they have a brand new playground space that is kid design. They have picnic tables, they have chairs out there. So again, it does create a ripple effect when you bring one positive thing into the community. A lot of different other positive things come into play. And we as a community health center can refer our kids that are borderline obesity to that playground. So I think having an accessible medical office in the community, you can go with your family. We do offer family appointments where you can be scheduled in a row. That is key to healthy living and also just better for the community as a whole, I think.
Okay, So it's about partnerships, linkages,
Right.
creating a critical mass of people to focus in on that particular development, that particular population. Yeah.
Right.
I think there are some positive developments within the medical community as well that shouldn't go unnoticed. So I was asked by a group of emergency room doctors at University of Illinois at Chicago Hospital, which ICD codes should trigger a housing inspections. ICD codes are International Classification of Diseases. This is sort of the diagnosis. And we have some ideas on which ones that should be, but it's not always terribly clear. So, you know, if a patient presents with certain symptoms, which of those symptoms should mean that a housing inspector should be deployed? So, so the way the Healthy Homes movement got started, unfortunately, was out of a tragedy. Congressman Carl Stokes from Cleveland said, I have 25 infants who died in Cleveland. The pulmonologist who did lung sections on these kids, they had been diagnosed with SIDS, sudden infant death syndrome. And he said, I'm seeing lesions in the lungs that are not consistent with SIDS. Something else is going on here. One thing finally led to another. They finally took a look at the houses. Each of those houses had a defective ventilation system. It was using basement air as supply air for the air handler. There had been a flood in that part of Cleveland, so there was mold growing in the basement. The spores had been distributed throughout the house, and the children died. So now, as a result of that, each doctor that goes through the Case Western Medical School does a rotation where they actually, doctors make house calls. They go out to the house with these housing inspectors, and they sort of, when they engage in their medical practice, they will think about, well, if this patient presents with these kinds of symptoms, then there should be a housing inspection. And some hospitals are starting to do that now. They'll actually hire or collaborate with a housing entity to get housing inspections done, usually for respiratory issues, but injury sources and the like. So that's the kind of collaboration that I think we're talking about. But putting meat on those bones is still before us. If you have an asthmatic patient, and let's say the child is allergic to cockroach allergen, where do you want to focus your attention as a houser? Probably on the kitchen, right? If he's allergic to dust mites, maybe there's something going on in the bedroom. So that kind of detailed, patient-centered focus in the housing context, I think is fruit. And you're starting to see more hospitals, because now they all have to do community needs assessments. They're going to be reaching out to people in the housing world to say, look, we're medical care providers. We don't really need to, we don't know how to do housing inspections. So there's a great opportunity there, it seems to me, to make that connection that we've sort of talked about here theoretically, make it practical, and bring it down to the level of a particular patient diagnosis and a particular housing inspection protocol. And of course, remediation.
That's a great example, and I would just say also probably the reimbursements for Medicaid now are related to the people coming back and the problem not being solved. So there's probably a little bit more pressure on the hospitals to get to the source of the problem,
do you all understand
to prevent
that?
the problem. Yeah. Okay.
I'll give you two good examples. Unfortunately, you probably don't have a chance to have this conversation in North Carolina in the next couple of months, but I'll give you two examples from expansion states, Medicaid expansion states. And then I'll give you an example from one that's not, so a little hope here. But in Connecticut, for example, there are, they were an early adopter in the ACA. They started about a year and a half before everybody else. So all of a sudden, they're seeing an expansion population. These are single adults between what people who qualified for Medicaid all the way up to 138% of area median income. So they picked up a large number of people who we all thought maybe would be healthy young people. They turned out to be more single adults, older, with severe substance use problems. And by the way, there, California, a number of other states, it's well documented. When these folks got health care, they went to the hospital and they got treated, and health care costs went up. Okay, and everybody said, see, health care costs went up. Guess what? 3 months later, it started to go down. So all of the data, and there's some good data out on that now. But in Connecticut, they actually, for those of you who work in the homeless arena, they actually took what is called the HMIS data, the Homeless Management Information System. And they matched that against Medicaid claims after the first year of expansion. Surprise, surprise, the top 1,300 people in shelter use accounted for $67 million of medical care the year before. 1,300 people, mean over 50,000, some folks up into the 300,000s. And then they could go right into the codes. They knew they could see the codes, they could see what was going on. And these are people who are obviously living in not so healthy places because they can't even get into the bad housing that's not so healthy because they're outside of the bad housing that's not so healthy. But guess who's sitting every day now with the housing coalitions, the local housing authorities, and the state housing agency? The Medicaid director herself, the two large organizations that manage health care for people with low incomes, families, and singles, and the hospitals have formed a coalition around this issue. On what can we do differently? How can we begin to shift money? The 16 hospitals with the super utilizers in Kentucky have all said, what dollars do we need to put on the table for housing? After 1 year or 1.5 years into an expansion, 16 hospitals in Kentucky sitting down doing this, okay? Now, interestingly enough, what happened with Medicaid in this country is the numbers went up in almost every state that didn't take expansion because there were people out trying to help people get enrolled. So there's now a new person looking at the intersection of housing and healthcare in the state of Virginia. That's his principal responsibility in the governor's office. The intersection of healthcare, looking at the social determinants, trying to figure out what can be done, even without expansion. Same with Georgia, without expansion. And then obviously the experience in Louisiana post-Katrina. So yes, on the financing side, we're beginning to see a few light bulbs where folks who have a true investment on the healthcare side now want to participate. And I would say every housing authority. And we should be looking for a health clinic. We have the federally qualified health centers funding today like we've never had before. Let's exploit it. Let's sit down with every housing authority. Let's sit down with the Y. Let's sit down in our local communities now, because that infusion of resources from the ACA isn't just in the expansion states. So while we're fretting a little bit here in North Carolina, I think that there's some things that can be done. And we can look to some of those examples around the country. It's still a little too early to see the outcomes of some of those discussions, but I think we're at a really good point to do that.
Mm-hmm.